This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Well, imagine you're on a call. The scene's tense, the story is unclear, and something just doesn't feel right. You might be standing in the middle of a situation involving intimate partner violence or domestic violence, even if that's not what the dispatch notes say. And these calls are among the most complex and high risk that we face for police officers and also for the person experiencing violence and, yes, folks that work in EMS. Survivors told researchers that they'd often only call 911 during the most extreme events. And when paramedics arrived, many felt that they received minimal support. I have joining with me one of the key authors from the study, Rory Marshall, and I want to give him a chance to introduce himself and just tell the audience about yourself before we get into some things I want to bug you about from your article.
Awesome. Yeah, thank you for having me today, Bram. Really appreciate being here and the opportunity. I'm Rory Marshall. I'm a paramedic with British Columbia Ambulance Service. I've been in that for almost 10 years now. I'm also had a stint with Alberta Health Services, EMS, and then some work in New Zealand and Central America as well. And then on the research side, I did my undergrad at Vancouver Island University before pursuing my Master's of Science at the University of Saskatchewan, and then my PhD at the University of British Columbia, Okanagan, and then now I'm a postdoctoral fellow at the University of Michigan. So doing a ton of work initially, more cardiovascular physiology based around CPR and hemodynamics and cerebral blood flow. And then in my PhD work, had an opportunity to get into the intimate partner violence space, initially with a look at kind of seeing how we could better address intimate partner violence called brain injury in paramedicine. And then through kind of some initial investigations, we're like, well, hold on, there's so many gaps around supporting survivors of intimate partner violence. We need to start there and see how we can mobilize research to better support survivors of violence and provide kind of the best services we can as those emergency health professionals. So transitioned into that work and keeping that going and expanding from paramedicine into community response in some different areas with our group at Michigan now. And so, yeah, just a lot of really exciting opportunities and always to getting to work with some really great people. And yeah, really looking forward to being able to talk about our research today. I know our team did a ton of work on this, and I'm super pumped to share it here on their behalf.
So, just in your introduction, I caught some of the motivations that you have for conducting this study. Maybe you could talk a little bit more to that, but for sure, tell me about why you set this study up the way you did. Maybe, more about the dynamics of the study, because you were trying to find out some stuff here. So tell me more about your motivation and more about why you set up the study the way you did.
Yeah, absolutely. So I was really fortunate. I didn't grow up in a home with intimate partner violence, but have a lot of kind of personal connections through other family and friends. And so it's a very important topic to me and something that I really want to. I see a big opportunity to support people, and this was just a way within the work that I do that I felt we could do that. So when we looked at this study, we initially there's a really minimal amount of work in paramedicine about intimate partner violence. And as you'll know from kind of everything to do with EMS research and paramedic research, so much of it is just people try and apply things to medicine exactly as they are in medicine into paramedicine. And for a whole number of things, there's challenges there and different bits and pieces. And so we started looking, and there's a very small amount of research in paramedicine and intimate partner violence at all. And then essentially nothing looking at that brain injury piece as well. So we did a survey of almost 700 paramedics across Western Canada, asking about intimate partner violence and then intimate partner violence caused brain injury, and looking at a bunch of different domains. And so we'd done that study and found that there were some areas that paramedics were felt really strongly in and were performing well, in some areas where there was room for improvement, and a lot of things around like self-efficacy and there were some kind of knowledge gaps as well. And then thinking about intimate partner violence caused brain injury, the same piece. So we are like, okay, we've probably got a disconnect in what we know should be happening and how we should be managing survivors of intimate partner violence and as paramedics. But what are these like? And we wanted to look at the clinical interaction from the patient perspective as a perspective that can be quite often missed, and then through some ongoing work, also the paramedic perspective. So this is the first study in kind of a line of work at the moment, gathering that patient perspective. And to give you an idea of how far back we are at this intersection, there's no until recently, but it's still kind of preliminary, but there's no like hard, fast, definitive evidence that paramedics are seeing survivors of intimate partner violence. Anyone that works clinically knows that we see these patients on a daily basis, but that's just like the level of lack of evidence there is so strong. And so we wanted to get these patient perspectives and say like, hey, no, like these are patients that are calling 911 for violence caused reasons. And this is their experiences when we're attending to them and what kind of opportunities we have there. And that's a big thing I want to stress because I know a lot of the work can seem a little doom and gloom and like almost like a hit piece on paramedicine, but it's like, well, no, what we're really trying to highlight is how paramedics have this opportunity. And if systemically, organizationally, culturally, we can set paramedics up, we can really mobilize paramedics to be this expert resource for survivors.
Yeah, and what I like about what your explanation just showed is that there are some real quantitative numbers out there that shows there's a concern there, and the gap that you found was that the survivor voices aspect wasn't heard.
So intimate partner violence caused brain injury is something that the research is showing is very common, probably in over 80% of patients. Um, and this is something that has a really high likelihood of affecting a clinical interaction or an interaction with any kind of services. So we see this very frequently um, with people that have experienced trauma, but then also people that have experienced a brain injury and just like cognitive impairment. So like delayed recall, inconsistent recall, inability to focus, these kind of things. And if we think about that from the context of a paramedic sitting in someone's living room having a conversation, it can be really challenging because if you're, as the practitioner, unaware that something could be causing kind of maybe inconsistencies in storytelling or like difficulty answering questions, it's really easy for patients to get written off as being like drunk or using substances or just like insubordinate, for lack of a better term, and can see like frustrations coming from the practitioner and just leading to like a decrease in care. And so the brain injury piece in intimate partner violence is really, it's so prominent and it can come from like that direct, indirect trauma, like being punched or hit directly or pushed down the stairs, getting those indirect mechanisms, but also, and wildly common, is this non-fatal strangulation aspect. So those two mechanisms making it a bit different than your standard like sports concussion or maybe a concussion from a motor vehicle accident. And the repetitive nature of intimate partner violence means that survivors that experience repeat violence are likely experiencing repeat head injuries at the same time, and head injuries, brain injuries. And so it's difficult because you're not getting like an NFL star that gets hit in the head and then goes into concussion protocol and sees all the doctors and is out and doesn't have the financial stress and anything. We're seeing that a lot of survivors and the evidence is indicating that they're sustaining that head injury, living in that stressful environment, waking up, being parents, going to work, doing these things, dealing with that shame and stigma, all while managing like these repetitive brain injuries.
Hmm.
And so it's something we really want to build in to when we're thinking about care for intimate partner violence. It's not something like paramedics aren't going to be doing concussion rehab in the field and definitive
Right.
diagnoses and text and anything like that. But it's like if we have paramedics being aware and then able to relay that as we position people to enter the healthcare system or use other services, it's really important and can do a lot of benefit. So we really want to stress that it's a component of intimate partner violence situations and needs consideration. But the context of all these settings overall is really important too.
And what you're doing is painting a big picture, and that's incredible. And part of that picture came down to you talking about these challenge areas, and I mentioned them in the intro.
Yeah, so two parts there. The first one, we came up with the challenges. So the team we had working on this was phenomenal. Nicole Merritt, Keelan Gorman, Tori Stranges, Paul Van Donkler, Simon Sawyer. We were all working together and used an interpretive description approach. So Sally Thorne at the University of British Columbia came up with this as a qualitative approach for applied disciplines to produce data that's useful to the discipline. So while kind of a lot more theoretical qualitative methods can produce some really good insight and philosophical things, it's not always useful for disciplines like nursing, that's Sally Thorne's background, or paramedicine. So this interpretive description approach uses the background of the research team as a strength in the research, like Nicole is also a paramedic and an intensive care nurse and a research associate, and Simon Sawyer is a practicing paramedic in Australia as well, and then a good diverse research team and medical background from the rest of the team. And so we were able to combine our insights and both interpret what the participants were explaining and also describe it in the context of paramedicine and intimate partner violence in that intersection. And it's similar to kind of traditional coding and qualitative methodologies but you're looking more for patterns. And it starts with like a very open look at patterns and then refining and refining and kind of seeing what emerges the most consistently and incorporating all the voices. So that's kind of how we reached those core challenges and then house different things under them. And um, a challenge in intimate partner violence is because situations are so complex and so diverse, that it can become difficult to get at the nuance without having an 8,000 page paper and being able to encompass every situation. So we took the pieces that were the most common and encapsulated the most portions of the experience of the survivors. Um, and then shifting gears and thinking about the representation of survivors in general, we can only speak to the experiences of the survivors that were in our study. Um, if we had 100 people saying the same thing, that 101st person might say something different, and then this is valid as somebody else's. We saw that a lot of the findings, especially on the experiences with violence, were consistent with the literature typically of it being cyclic and escalating and um, just these things that are super common, super well documented. And I think you would develop some different pieces and different aspects and different experiences if you were to gather more survivor experiences. So while this gives us a good initial insight, it is limited to these survivors, but there are a lot of themes that are consistent across other literature with the things that these survivors have experienced and what other survivors may be experiencing. So we'd love to keep, and we are pursuing different avenues of research to look at this and get more experiences and then use some different methods in the future for developing different levels of evidence.
Yeah, so you're doing a great job of painting a picture here, and it sounds like that the more you do of that, the more clarity that we'll have. And I want to ask you, what surprised you most from some of these survivor accounts?
Yeah, that's a really good question. Um, It's it's really challenging because it was absolutely heartbreaking working through some of the transcripts and hearing about the clinical interactions that survivors have had. And I do want to highlight again, some of the experiences were really good. Certain survivors, because often they're having multiple touch points with EMS and paramedics, were saying that at certain experiences, they were getting phenomenal care and like really compassionate personal care from certain paramedics. And so there are medics doing a great job in a system that doesn't set them up for it. Unfortunately, the more common experience um, was biased and discriminatory and not trauma informed, and so it was heartbreaking to learn about the experiences and just how poor some of these situations had gone for certain survivors when
So
they're
was it
in
more about like
seeking
it
help.
was it more about like the EMS professional saying being blunt with them or not acting like they cared or not doing a thorough look? Was it some of that stuff you think, or
Yeah,
give me more insight?
yeah, absolutely. So, just some of the things that were said to survivors, and um, they'd say things like, "I can just picture this paramedic saying like, oh, like you should just leave, or like you should learn that like by now like this is going to keep happening, like this is your fault, you need to leave." And the
Yes.
exact opposite of a behavior we want from responding professionals in intimate partner violence settings. And the stories of intimate partner violence are always just heartbreaking. Like it's so infuriating. This is such a prevalent problem in our society. um, and then when we do have survivors seeking help and using our paramedic services and those public services to get help in these situations, that we were at many touch points as paramedicine not meeting those people where they're at and providing the services we should. And so it's, I wouldn't say it's surprising, because based on the data available in the field and kind of how paramedics are trained, especially in Western Canada. Um, it's a lot more high acuity physiological emergency training and a
Hmm.
lot less biopsychosocial considerations. And now, as we're seeing a shift in healthcare service utilization and EMS utilization, our training is lagging in what we're responding to and how we need to be equipping our paramedics to respond to these situations to the most benefit. So, yeah, it was very surprising in the worst way. Like, we weren't that surprised, but we were absolutely heartbroken to see some of these findings and see how, in general, the pattern was survivors were feeling underserviced and mistreated by paramedics and paramedic services, which was frustrating.
Yeah, that quote that you gave that basically puts the blame back on the person who's being victimized is something that I have not heard a EMS professional push out to a victim, but I definitely have heard law enforcement officers, push that narrative and, be pretty aggressive and mean about saying something like that. But, you know, I think that they are trying to add pressure so that they could hopefully get them out of the situation. But gosh, it
Yeah,
obviously doesn't feel that way on their side from what they're saying.
yeah,
So,
my my hope, and this is what we're learning from some work that's under review right now with paramedics, is the paramedics really want to support survivors. I mean, everyone working in paramedicine knows there are better paying jobs with better hours and less trauma exposure and all these things. So anybody that's working in paramedicine wants to be in paramedicine, and that typically comes with wanting to help people. And I think it might be, I'm hoping, and if we give paramedics the benefit of the doubt, that, yeah, they're trying to leverage, okay, what can I say that's going to get through to this person so we can support them better? It is the wrong approach. We know it's the wrong approach. We know it doesn't work, and we know it's not trauma and violence informed. And I think that's one of the hiccups, and it kind of illustrates really nicely there that paramedics are going to try and support people, and if we don't equip them to support people well, then it leads to a variety of methods. And some, like the cases where people are being cared for really well, work great, and others where people aren't being cared for really well don't work. And
Oh my
so,
gosh. So that's a great point. So give us some tips now. Like, things that are easy on our next calls, on our next intense situations. Give give us the list. What do you what sounds good? What should work?
yeah, the World Health Organization's guideline for caring for people experiencing intimate partner violence is the LIVES approach. So it's LIVES. And then listen to the survivor, inquire about needs and concerns, validate their experience and how they're feeling, enhance safety. So whatever that looks like for them, and then just provide that ongoing support. So that's part, and it's built into the Simon Sorey guideline, which then works off what we're calling the 4 Rs. Basically breaks down these really essential factors that I've been calling it the 4 Rs, with like the recognizing intimate partner violence, whether that's through screening or situational awareness or whatever it is, which is something paramedics can do right away and without any changes to guidelines or anything like that. Just being more aware, knowing signs and symptoms, knowing those pieces, and then responding. So that's saying the right things at the right time. And we find that we've been getting really good pushback, or not really good pushback, really good feedback when we're working with groups talking about trauma and violence informed approaches. And there can be a bit of kind of this old guard mentality at times that is like, oh, like that's a bit foo-foo, whatever. And we're like, well, no, like what this really means is having interactions with people in a way that isn't going to re-traumatize them, and being aware of the potential trauma they've been exposed to. And from a paramedic setting, I think we can often forget the power dynamic of a responder. And like, let's say someone's sitting in the back of the ambulance, and depending on how your chairs are configured, if that person's now in a corner with the chair in it, and like a big provider in a uniform is standing over them, and they're not meaning to be threatening and these kind of things, and then they start with some kind of harsher language, versus if they're sitting down and coming in kind of softer, like these kind of things, and just responding appropriately, reinforcing that things are not survivor's fault, like all these things, validating that experience. And then referral is another one of these. So this is kind of more of an infrastructure gap, and it depends on different systems and different services and different healthcare approaches. But making sure that there's a link to the next most appropriate professional or service to deal with it, and or deal with this situation and best support that survivor. And that may be, if somebody is staying in community, knowing your local domestic violence resources and being able to give them that phone number saying, hey, we've got some time here, given, I mean, it's all situational, but if your situations, you've got time, their partner's not around, like these kind of things, hey, why don't we call them now and see if we can get somebody here to support you or initiate that process. Or if it's at the hospital, um, making sure that continuum of care goes in to the triage nurse, to the attending nurse, to whichever physician they're seeing, like those people, and maybe it's to that social work consultation as well in the hospital, whatever that looks like, just making sure there's a referral. That's challenging to integrate right away as paramedics because it takes an extra step often in systems that aren't super accommodating for it. Um, but really important piece. And that final one in out of 4 Rs is record. And that's just talking about documentation. And this is something that we're now seeing in the work we're doing with paramedics and some other services and law enforcement and things like that, can be really challenging, because in paramedicine, your report is a medical record, a legal record, and like your license saving record, depending on all these different things. And there's a lot of challenges paramedics have been reporting in some of this other work around knowing what to write in the report, how much objectively versus subjectively, and these kind of things. And that is a tricky balance. And so that guideline Simon Sawyer's group put out in 2021 has some a little bit better explanation on that, but just making sure that it is clearly documented, and so there's that record as well. And it's worth forwarding and continuing that referral on suspected suspicions, because we're not expecting paramedics to be kind of the judge, jury, and executioner of, yep, this is an intimate partner violence situation. Yeah, yeah. It's just saying, hey, there's enough indications here that I have concerns. Let's refer this to somebody that's better equipped to set this person up for success, investigate this kind of thought process and go from there. So just to kind of summarize all that, it's to recognize intimate partner violence when you're on scenes, when you're in a house, something doesn't quite feel right, to respond in the right way, thinking about your positioning, your body language, the language you're using, the questions you need to ask, the ones you don't, the exams you need to do, the ones you don't, and then making those referrals in that continuum of care, whether it's in hospital or in community, and then documentation and recording. And maybe your service organization has a way they want you to do that, or if they don't, how it is in your free text narrative, whatever that looks like. So those principles and incorporating the LIVES approach from the World Health Organization, and that's actually in the Sawyer guideline as well.
Well, and this is also highlighting the fact that we need to pay attention to potential head injuries, and we need to look and assess people's necks, right? To make sure that there are not things that we're missing as part of that assessment.
Yeah, that's definitely something that we're as part of the ongoing discussion. Um, it's it's a really challenging area. The Strangulation Institute does some great work on signs and symptoms, kind of that redness around the neck. You see burst blood vessels in the eyes, these kind of things. Any general trauma to the face, like slight cuts, just like things that don't normally happen. Um, and the one of these challenging pieces, though, is depending on how people are strangled, it and it it can be very difficult, and there can be no signs, like physical signs. And the language we're using as paramedics or as healthcare providers, wherever we are in the system, um, can be really important, because we have talked to advocates, so people working in shelters, counselors, social workers, things like that, and when they're interacting with survivors, if they say, "Oh, were you strangled?" They're like, "Oh no, like I wasn't strangled." But if they say, "Oh, like did they ever put their hands on your neck?" And they're like, "Oh yeah, like all the time." Like or like, "Did you get choked out?" And of course, choking's internal, strangulation's external, but just the language. And so it's not about us using the correct language in like anatomical terms with patients as paramedics, but more us using language that our patients understand and that they can communicate in. And it's a lot easier to say somebody put their hands on their neck, like a yes to that, than I was strangled, because that's very confronting. And so the strangulation piece is very, very, very common, huge lethality risk anytime anyone's strangled. Like if you think about it functionally, you're cutting off someone's air and blood to their brain potentially. Um, and it's a huge power and control piece, huge, huge lethality risk. And if somebody is being strangled, they are at a really elevated risk. And as paramedics, it would be really important to try everything you can to advance that situation to the next resource in a safer space immediately. Um, it's just it's so, so important. And then that paired with head trauma, I mean, we know physical violence targets the head, neck, and face. So it makes logical sense as soon as you think about it. Somebody gets struck in the head repeatedly for years sometimes, they're going to sustain a lot of concussions or mild TBIs. As that language shifts to, that'll kind of change a little bit, but it it's something to look for. And oftentimes, like, violence escalates when people are using substances. Absolutely, violence escalates when people are using alcohol. Um, Violence escalates during stressful situations, and trauma itself has a lot of overlap with intimate partner violence. Like we always say, something that comes up And I've heard people say it all the time is they're like, oh, anyone that you think is like intoxicated on alcohol, you're like, always do a blood sugar because, it shares so many symptoms. And I use that example because our
Mm-hmm.
staff here really respond well to that. Because they're like, yeah, that makes sense. I'm like, but if you think that they're confused or irritated or agitated and are not remembering, you think it's substances, just be like, well, I'm here for violence. They've probably been hit in the head. We don't need you to diagnose concussions. You can assume they have one. And it's
Yeah.
probably not their first one if they're seeing an ambulance for violence because it just comes up so frequently. So yeah, it's almost like the rule would be that someone experiencing violence has a brain injury, and the exception would be that they don't. And that's kind of how I think we have to shift the mentality as we're approaching these situations and incorporating intimate partner violence caused brain injury into our care for people experiencing intimate partner violence.
I have to say, the title of the article is really powerful. Let me read it. The questions made me realize how many times I could have been saved and removed from that situation. That was a quote, and it's the experiences of patients attended by paramedics for intimate partner violence and actionable implementations for paramedicine. You published this in BMC Women's Health. Great job. Congratulations on your article. And Dr. Marshall, thank you for being with us and letting us know more about you and your work today.
No, thank you so much for having me. It's a pleasure to be here and share the work of our team. Again, I can't say enough good things about Nicole, Tori, Keelan, Simon, and Paul. All done a ton of work on this. Great scientists, great healthcare professionals, and we're really happy to be able to highlight this work that we care a lot about and see a lot of value in, and want to just keep the conversation going and supporting paramedics to be expert resources for survivors and seeing if we can action that into moving survivors from situations that aren't safe and aren't working for them to situations that do. And so that's kind of our vision and something we're really hopeful for and keep pushing forward through all this work. So thank you again for having me, and it's an honor to be able to share this work.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and right. And you think, well, maybe this is someone that can help. Well, you said that, and I said that during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chabot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month, free for you to review on our website at iphmi.com, and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.